patients, they go through a genetic test, they get a result back. A lot of people view genetic tests as good, bad, and if I clear one genetic test, then I don't have to worry about the disease later on. Is that a proper view that should be communicated to patients, or a patient should be allowed to walk away with? Or should it be more of the risk management, saying that we don't know what may have caused your disease, but you still need to kind of look at it and be followed up for it later?
Oh, thank you for this question. Because if we go to another slide, which is this here, you will, I can try to answer your question. And I think patients, the best feeling of the patients in the ambulatory room is when he is facing different people, not only the geneticist who has to explain the genetic nature of the disease, the risk of transmission, and so on. But I think you need also one disease specialist, because very often they have some question about transmission, but many of the questions is about the disease. What's happened to me? What I have to do? Which kind of examination I have to do? Which is the risk of recurrence? In some cases, you will have in the same person maybe the expert and geneticist, but in other situations you can do that job with many people. And there is another point near to your question, which is how far we should go with the explanations of the disease and the risk of the disease. And I think I learned from the management of VHL disease, which is a very tough disease, very complex disease. And in these patients, you will need strict follow-up, many examinations, and also since that disease has different tumors in different locations, who needs different specialists. You have to build up a reference point for the patient. Then you will suggest, now we should go to the ophthalmologist to do the retinal operation. Maybe we go, at that moment we should do something with the kidney, but they need a friend. And that's why when I have to speak with the patient, to explain, I will try to explain everything. I don't miss, I don't forget. I'm saying, well, this is the disease. Those are the options you have. We can help you in that way. I will be always available for you. The patient will have my phone call. They can call me. A few minutes ago, I will try to answer one email of a patient and so on. And this way, we can manage at the best this very complex disease. Obviously, this is costly because you spend much time, more time with the disease, but I think that in complex hereditary disease with multiple tumors like in pheoparaganglioma, you need such kind of a relationship with the patient. Obviously, you can do also a different way, but I feel that a multidisciplinary approach, a real multidisciplinary approach, and a real good relationship with the patient. Obviously, after you see for 1 hour a patient, after 1 hour, you can go to drink a coffee together because you spend more time.
Alan? Hello, I have 2 questions actually. The first one is, we have 2 new genes, and I'm interested in what the difference is between syndromic and familial non-syndromic.
Oh.
And the second question is just how often should a patient consider being retested with the discovery of new genes as we go along?
The first question is much more easy to answer. Syndromic means that you have some symptoms that make the diagnosis easy. For example, VHL. Sometimes you can have only the fear and maybe it's hard work, but most of the times you will have other symptoms like eye problems, like kidney masses or cysts or pancreatic cysts. So, for example, you have 2-3 different pictures, and this make the connection about the different picture, and you will have, this is a clinical VHL. So it's a syndromic and something that speaks to you. If you have a patient with high calcitonin and pheochromocytoma, for example, that's clearly a specific association and is a particular disease. Familial non-syndromic means that the only point you have is that maybe the father or the mother or the sister had the same disease without any other signs. And so this is the difference. Regarding the new genes, we really don't know what will happen. I showed 2 days ago that in a few years I collected many families without any other genes at that time. Now we know something. Possibly we have still 2 families without other genes, but maybe there are other mechanisms. Maybe we were not able to get the gene because it was occult mutation, something strange, and sometimes you also can have what is named a phenocopy. So this I think is not easy to happen in pheochromocytoma because it is a rare disease. But for example, in breast cancer, you can have a family with hereditary breast cancer due to BRCA mutation. But in that family, since breast cancer has a 20% prevalence in the general population, you can have also one patient without risk of transmission with the same disease. So this makes the situation a little bit complex. I don't think that Pheo can be frequent, but it can help also.